This chapter is going to be on ankle arthrodesis. What is this arthrodesis? Arthrodesis is actually the surgical fusion of a joint, isn't it? Okay. So several years back, arthrodesis was a routinely done surgery for several diseases, especially diseases of joints that cause severe pain or instability. Okay. Nowadays, though, we are slowly moving away from arthrodesis and more we are trying to do arthroplasties instead of arthrodesis. But even then, there are certain instances where arthroplasty is not possible at all, and in those situations, we definitely will have to do arthrodesis. So, what is this arthrodesis of the ankle? It is the surgical fusion of the tibio-talar joint. And what are the aims? So, remember, whenever we are planning to do a ankle arthrodesis, there are four aims that you have to keep in mind. One, we are trying to make a painless ankle. The ankle should be stable, it should be plantigrade, and it should be capable of weight bearing. So, the aim is to provide a painless, stable, plantigrade foot which is capable of weight bearing with a near normal gait. So, that is our idea here. So, what are the indications of ankle arthrodesis? As we all know, the most important indication is end stage ankle arthritis. This could be either a post traumatic case or an inflammatory or a degenerative case. Whatever the condition may be, any end stage ankle arthritis, you have to think about the need for an arthrodesis. Then severe ankle deformities with instability, avascular necrosis of the talus, failed total ankle arthroplasty, and neuropathic arthropathy. Neuropathic arthropathy is basically a Charcot's joint. In all cases of Charcot's joint, we cannot do an arthrodesis, but in selected cases, we can definitely try. Now, what are the contraindications of ankle arthrodesis? First and foremost, active or chronic infections at the surgical site. If there is an active ongoing infection, obviously we cannot do any implant surgeries, not even ankle arthrodesis. Then vascular compromise. This is very important when a patient has a peripheral occlusive vascular disease such as diabetes mellitus, chronic smoking and all. In these conditions, always think about the complications. There could be infections and the patient may end up in amputation. Inadequate soft tissue envelope, compromised wound healing potential, again smoking and diabetes, significant adjacent joint pathology. So, whenever we are doing an arthrodesis, remember, whenever you are doing an arthrodesis in a particular joint, the adjacent joints would be maximally affected because whenever a joint is completely stiff, the load transfer is going to get shifted onto the adjacent joints. For example, if the ankle is arthrodesed, the foot and the knee will be affected. If the knee is arthrodosed, what will happen? The ankle, the hip, and the spine will be maximally affected. So, if in a particular patient the foot and the hind foot is already involved, the knee is arthritic, in those conditions, it is wise not to do an ankle arthrodesis. Now, there are certain conditions where the patient is medically unstable or not fit for surgery. In those conditions, also, we can skip doing this surgery. Now, whenever we are doing an arthrodesis in a patient, remember we are actually doing a life altering surgery. Okay, the limb will be completely stiff in that patient, that joint would be completely stiff, the gait of the patient would be changed, the patient may not even comprehend to full scale what is going to happen, isn't it? So there can be a chance of lot of litigation. So it is very important that you document everything clearly. All your documentation should be perfect. Okay, this is very, very important. So what you can do is that you can start with a thorough history. You take history of any prior injuries, prior surgeries, what treatment was done, what were the symptoms, everything you should take and record in your case file. Then you go in for a physical examination and check for alignment of the limb, stability, range of motion, neurovascular status, and gait pattern. Then you go in for imaging studies. You can take weight bearing, AP, lateral, and the Mortis view of the X-rays. Then you can also take CT scans, especially if there is gross deformity or bone loss. And long leg alignment films or scanograms are very, very important for surgery. When you are planning a surgery, especially if there is a deformed limb, you must always take a scanogram. Otherwise, you have a difficult time in your surgery planning the alignment of the foot and the ankle. Now, long leg alignment films should be absolutely taken when you have to evaluate for deformity that extends proximally, to assess limb length discrepancy, and also to evaluate adjacent joints. Now, what are the surgical approaches you can use for ankle fusion? Most commonly used approach is your anterior approach, which is very commonly done, and it gives you excellent approach to most parts of the ankle joint. Then you can also use a lateral transfibular approach. So this is an extensile approach where you are actually doing an osteotomy of the fibula. This gives you excellent exposure. Another thing is that you can even morselize that fibula and you can use it as a graft, or you can even use it as a strut graft if you want, and this is useful whenever there is gross deformities around the foot and ankle. Then you have the posterior approach. It is generally used only in revision cases or when you are planning a TTC fusion, which is tibiotalo-calcaneal fusion. In that situation, you can use a posterior approach. And nowadays, we even have the arthroscopic approach where we put in our scopes and debride the joint. That is, we enter the ankle joint arthroscopically and debride off all the cartilage from the undersurface of the tibia as well as the proximal part of the talus. Now, after removing the bone from there, we compress the bones and put two screws like this. Even these screws can be put in a minimally invasive fashion. Now, what is the optimal fusion alignment of the ankle? So, this is very, very important. You have to keep a neutral dorsiflexion, which is 90 degrees at the angle, always going for a slight valgus at the hind foot. This is very, very important. I make the point again when we will be talking about the subtalar arthrodesis in the other lecture. So please remember, while you are fusing any joint in the ankle and the subtalar joint, that area, remember, always going for a 5 to 10 degrees of valgus, never varus. If there is varus, the surgery is going to fail. The patient will have severe pain because of lateral overload. There will be much more worsening of the symptoms. The gait may be abnormal and the patient is not going to be happy. Always aim for a 5 to 10 degrees of valgus at the hind foot. Then you can match the external rotation of the affected limb by comparing it with the other side. There should not be any anterior or posterior translation at the talus. Sometimes what will happen is that you get a patient like this where you can see that there is arthritis of the joint and the talus is anteriorly subluxed when you compare it with the calcaneum. So while doing the surgery, you have to place the talus back under the tibia and you do the fixation like this. So always correct any of these deformities before doing an arthrodesis. Arthrodesis is not something that we do by putting screws in situ. You have to properly debride of the cartilage. You have to align the bones perfectly. Then only go in for arthrodesis. Okay, very, very important. Now, what are the steps of ankle arthrodesis? First, patient positioning and preparation. Supine position is preferred with a bump under the ipsilateral hip. Why do you need that bump? This will prevent the external rotation of the hip. Okay. Then a tourniquet should be applied, fluoroscopy should be positioned, and painting and draping is done. After this, you go ahead and open up the joint. Generally, the anterior approach is used. Anterior approach is generally used. You expose the angle fully, then you will see the undersurface of the tibia here. Completely remove it. Remove the cartilage and the subchondral bone from there. And then here also in the upper surface of the talus, you remove the cartilage and remove the tough bone from there till you reach bleeding subchondral bone. Remember these two recesses. This is the medial and the lateral gutters there on either side of the ankle. So remove the cartilage from there as well. Okay, please remember that. Many a time we miss that. So always remember cartilage from that area as well. And how long should you keep on debriding? You have to keep on removing the cartilage till you see small drops of blood appearing on the surface of the bone. When you see that, you know that there is bleeding bone underneath. This means that good quality bone is there. Fusion will take place without problem. and this sign is called the paprika sign. Paprika sign. This is something that we also see when we debride a case of chronic osteomyelitis. When we open up the abscess cavity after sequestrectomy, you will see a cavity with lot of granulation tissue and everything inside that cavity, and when you have to keep on debriding and removing all the granulation tissue and the dead tissue till you see paprika sign. Once you see paprika sign, it means good quality bleeding bone. Okay, so this is paprika sign. Once you get paprika sign, you reposition the ankle in whichever position you want. The correct position of arthrodesis, you have to keep the limb and you can fix the bones. Now remember, bone grafting plays a very important role in ankle arthrodesis. Okay, so don't feel shy in using bone grafting. You might feel that I'm already taking up the cartilage and destroying a joint. Should I touch the iliac crest also? No, don't think like that. Take as much bone graft you need and put it at the arthrodesis site. Otherwise, there is a high chance that it can go in for a non-union, especially if there are any bone voids. For example, you might be doing this for an avascular necrosis of the talus with a collapsed talus. You will see that there is loss of congruity in much of the joint and there will be large voids, or sometimes there is severe arthritis with lot of subchondral cysts. So make sure that you debride everything of the cartilage and then you fill everything with bone graft. Again, you have to use bone graft in any patients with a non-union risk, such as a smoker or in revision surgeries. You have to pack the entire joint with bone graft so that very good contact is available between the bone ends. Now, what are the implant options that are available for fixation? You can either use a crossed screw technique where you use multiple screws like this in crisscross manner to fix the talus to the tibia, or you can use plate fixation or an intramedullary nail, or you can use something called as Charlie's compression device. Whatever device we use, remember the key is to get good compression across the fusion site. Okay, this is what is important. Whatever implant you use, make sure there is good compression at the arthrodesis site. So this is a patient who has undergone arthrodesis with multiple screws. This is another patient who has undergone arthrodesis with an anterior plate like this. You can use it. Anterior plate is easy because we are going into the joint using an anterior approach, right? Then this is an intramedullary nail which can be used. Intramedullary nails are generally used only when you are planning a TTC. TTC is tibiotalo-calcaneal fusion. That is, along with the ankle, you are also fusing the subtalar joint. Then use the TTC nail or the tibio. TTC is tibio-talo-calcaneal nail. Okay. Now I don't know how many of you have seen this Charlie's compression device. So I did my post graduation 15 years back, and in a government hospital, and most of the patients who come to our hospitals are from a very poor financial background, and for all of those patients, most of them are manual laborers with some kind of an ankle problem. And whenever we are planning for arthrodesis, we used to use this Charlie's compression device, very cheap device. In fact, we used to have at least 10, 12 just lying around in our operation theater. Whenever a poor patient comes and we have planned for a ankle arthrodesis, we used to take a pair and get it autoclaved for surgery. Very cheap implants. And the other device that you need is Steinman pin. So what you do is that basically after you prepare the bone ends and reduce the joint in whichever manner you want, the accurate arthrodesis position, you pass this is your Steinman pin. This is a Steinman pin from the heel up into the talus into the tibia so that the position is maintained. Then you use a second Steinman pin and you drive it transversely across the tibia. Then you use a third Steinman pin and you drive it transversely across the talus like this. So two Steinman pins. Then you attach this device. So this is your Charlie's compression device, which can be used. A pair needs to be there. and there is a turning mechanism in the Chandler's compression device. You keep on turning it, and this will increase the compression at the fracture site. The advantage is that after 2 3 weeks, when you are taking an X-ray and you feel that the compression is not adequate, you can increase the compression also after surgery. The the best thing about this device is very cheap, very cheap. Hardly 1,000 rupees for the whole implants. That's it. Now let's discuss about wound closure and immobilization. So you have to close the wound in layers. You close the capsule first because all the bone graft, everything is inside. You close the capsule, then you prepare the subcutaneous tissue and put the skin sutures, apply sterile dressing and a well padded posterior plaster splint, and angle should be positioned in a neutral manner, never in equinus. Even a slight dorsiflexion is okay, but never in equinus. Okay. And post-operative cast has to be put once the edema subsides and the wound heals, and after suture removal, you can actually put a post-operative BK cast. Now, in the 2 to 6 weeks, what you will do is that you continue non-weight bearing and you can put a below knee cast, and you take follow-up X-ray at the end of 6 weeks, and see if there is proper union happening. If everything is progressing well, at the end of 6 weeks, you can change the cast and put a pneumatic walker like this. But gentle range of motion exercises can be started at the other joints. Ankle joint cannot be moved, so toes can be moved. Knee exercises, hip exercises, spine exercises, etc. can be started. After 6 weeks, low weight bearing is started. Initially, partial weight bearing with the walker support is started. Usually by 6 to 8 weeks, make sure that radiographically X-ray wise fracture union or the arthrodesis fusion is progressing well. Now gradually you can transit from a boot to shoes with orthotic support, and at this time you have to start physical therapy to improve the strength, balance and gait, and the patient must be advised to avoid any high impact activities for a period of 4 to 6 months. Now, what does the study say? Are the outcomes good or bad? If you look at the fusion rates, it is around 85 to 95% in most cases. Pain relief is seen in 90%, more than 90% of the patients, which is excellent outcome, and significant functional improvement is seen in almost all studies. And if you look at the long-term durability of the arthrodesis, it goes into decades. For decades, the patient will not have any problem with the arthrodesis. The only problem with such a procedure is that the ankle range of motion is lost, but the patient usually will have very good compensation from the other joints. Okay, that is why physical rehabilitation is also very important post-operative protocol. What are the complications you can expect from ankle arthrodesis? First is non-union and delayed union, malalignment which can lead to gait disturbances, infection, hardware irritation or failure, and progressive arthritis of the adjacent joints such as the subtalar joint, midfoot and the knee. Now what are the special surgical conditions that you have to keep in mind? First and foremost, if you encounter a smoker and you are planning for a surgery, remember these patients will have a high non-union rate. You have to use adequate amount of bone graft and make sure you take care of the patient well. Advise them adequate non-weight bearing, put a good cast and ask the patient to stop smoking. Okay, this is very important. Similarly, in diabetics also, these patients may have some amount of diabetic neuropathy, and make sure that the patient does not have any evidence of Charcot's joint. Otherwise, your surgery may fail. And also, the second problem with diabetics is wound complications, isn't it? That is also important. In osteopenic patient, only thing is that you have to do a rigid fixation. Either use a LCP or an adequate compression should be given at the arthrodesis site, and you will have to do adequate amount of bone grafting as well. Now, TTC nail. What is TTC nail? As I told you, it is the tibiotalo-calcaneal nail which is used for fusing the ankle and the subtalar joint simultaneously. It should be used if there is any gross problem with the subtalar joint, especially if there is hindfoot valgus, varus, and all those problems are there. May be difficult to correct it just with an ankle arthrodesis, and if you don't fuse the subtalar joint as well, these patients may come back after 1 year or 1.5 years with pain in the subtalar joint. So it is better to discuss with the patient and fuse the subtalar joint as well in a single sitting. Now, as I told you at the introduction, slowly we are moving away from arthrodesis to replacement. Okay. So, how do you compare and contrast ankle fusion with ankle replacement? So, if you look at the indication, ankle arthrodesis can be used in a wide variety of situations like end stage arthritis, deformity, instability, even in infections, chronic infections, and all. You can use an Ilizaro to fuse the joint. But in the case of total ankle arthroplasty, the indication is end stage arthritis with good alignment. If the alignment is not good and if there is gross instability and all, then you cannot use a TAA. If you look at the age group, ankle arthrodesis is better for younger patients, TAA is good for older people. Functional outcome, if you say, ankle arthrodesis will give excellent pain relief, but there is no ankle movement. TAA will give you good pain relief as well as good mobility at the ankle. So, advantage for TAA here. Range of motion again will be absent in arthrodesis, it would be preserved in replacement. If you look at the gait pattern, it is altered in arthrodesis. Near normal gait will be present in total ankle arthroplasty. And if you look at the adjacent joint degeneration risk, higher risk for arthrodesis, lower risk for arthroplasty. Another criteria that you can see is implant survival. There is no question of any implant failure or anything after arthrodesis has taken place and fused. There is no risk for any of those things. But there is always a risk of implant failure after about 10 to 15 years in arthroplasty. Then, if you look at the chance of revision, it is rare in arthrodesis, possible because of loosening and wear and tear in ankle arthroplasty. If you look at the weight bearing has to be delayed until fusion is confirmed in arthrodesis. Early weight bearing is possible in ankle arthroplasty. Look at the complications, non-union, malalignment and adjacent joint arthritis for ankle arthrodesis. For arthroplasty, it is loosening, infection and failure. Contraindications for arthrodesis is bone loss and infection. Total ankle arthroplasty, severe deformity, osteoporosis, infection. There is a long list of contraindications. Technical demands wise, ankle arthrodesis is less demanding, while TAA is quite technically challenging. Long term satisfaction is high in both ankle arthrodesis and ankle arthroplasty, but many studies say that if you compare both, ankle arthroplasty, the outcomes are slightly inferior to arthrodesis. Maybe it is because we do arthroplasty in a older age group. Maybe that is a reason, but we are not sure. Cost wise, we all know arthrodesis is much lower. So this is the differences between arthrodesis and arthroplasty at the ankle. Thank you.